We'll now move on to the biparietal diameter and the head circumference. Why do we have both measurements? Well, this is again an issue of a dichotomy, the dependence on shape versus the ease of measurement. Now, the biparietal diameter is dependent on shape, whereas the head circumference is not. So a fetus can have a narrower head called dolichocephaly, can have a broader head, but those would influence the biparietal diameter, but that shape change would not influence the head circumference measurement. However, the biparietal diameter is easier to measure than the head circumference. So let's look at the biparietal diameter as a measurement. Again, this is a relatively easy measurement. I think of this as a two-dimensional measurement. You must get the right height on the skull, and the beam cannot be inclined. So you must get the right level, and the beam must not be inclined. So you have to be correct in 2 dimensions. However, once the beam intersects those 2 points on the fetal calvaria, then you could rotate the transducer through a 360-degree arc that intersects those 2 points, and you would get exactly the same measurement as you did in any of the other planes through that 360-degree arc. So we again have an infinite number of planes of section that will give us precisely the measurement we are looking for. Again, the measurement endpoints are very good. We are measuring from bone to bone. Bone is very bright, and it represents an excellent endpoint of measurement. So in fact, there are very few pitfalls in the measurement of the biparietal diameter. By contrast, the head circumference is a relatively difficult measurement. Why? Because it must be correct in 3 dimensions. 2 of the dimensions are the same as the biparietal diameter, so you have to reach the appropriate level of the skull. Secondly, you cannot incline the beam through the skull. But thirdly, in the case of the head circumference, the plane of section must be exactly parallel to Reed's baseline, which means that in effect, there's only one plane that is exactly perfect for measuring the head circumference. Now, in fact, obviously, there probably are a number of planes, close to that plane where the difference in measurement would be too small to compute. But I think you get the idea. By comparison to the biparietal diameter, where we have a great deal more latitude for getting the correct measurement, with the head circumference, we have a great deal less latitude. Nonetheless, the endpoints of measurement are good. Again, we're measuring bone to bone, excellent measurement endpoints. So again, the pitfalls are reasonably few. Okay, how do we know we're getting the correct biparietal diameter? What you want to see to know you're getting the measurement at the right level is the 3rd ventricle flanked by the thalamic nuclei. That tells you you're at the correct level. How do you know that the beam is not inappropriately in an angle of inclined to the perpendicular? And you do that by looking at the calvaria. You want the calvaria to be perfectly symmetrical. So we have symmetrical calvaria telling us that the beam is not inclined, and we have the 3rd ventricle flanked by the thalami. So we have the correct plane of section. The only remaining task is to properly position the electronic cursors at the endpoint of measurement. I measure middle to middle, which is satisfactory. Many people measure leading edge of the nearest calvarial bone to leading edge of the farthest calvarial bone. Either is perfectly acceptable. And we will call that measurement 75 millimeters. So the correct BPD of this fetus is 75 millimeters. Now, this is not the same plane that you would use to measure the head circumference. Why? Because too much of the cerebellum is visualized. So this is an incorrect plane of section for measuring the head circumference, but we measured it and it came out 257. So in that example, we got a head circumference of 257 millimeters and a biparietal diameter of 75 millimeters. This was correct, but this was incorrect. How would we have changed the plane to get a perfect plane for the head circumference? Well, to do that, we want to line up the cavum septi pellucidity with the third ventricle flanked by the thalami, but now instead of seeing the cerebellum, we want to see the tentorial hiatus. Some people call this the arrow sign, where the frontal horns and the cavum and the opposite frontal horns are the feathers of the arrow. The interhemispheric cistern and the third ventricle are the shaft of the arrow, and the tentorial hiatus is the point of the arrow. So we now have the proper plane of section for our head circumference measurement. Unlike the biparietal diameter, where it's perfectly legitimate to go from leading edge of bone to leading edge of bone, or middle of bone to middle of bone, for the head circumference, the cursors must be placed at the outer edges of the calvaria, and then the ellipse must be fit as tightly as possible to the bone. It should not include the skin of the scalp, so only the bone. And that looks like a very good measurement, so we will say that 264 millimeters is the correct head circumference. If we measure the biparietal diameter on that same plane of section, again, we expect to get 75, because the one plane of section that is appropriate for the head circumference is among the infinite number of planes of section that is appropriate for the biparietal diameter as well. So you can see that making the error of being too inclined such that you see the cerebellum in the measurement instead of the tentorial hiatus, then you can appreciate that error causes the head circumference to be smaller than it should be. So we know the direction of the error and we know the magnitude of the error, and it is unlikely that those 7 millimeters would have a significant impact on our prediction that we're going to make from that measurement. So it's a mistake. It's a mistake we don't want to make. But if we make the mistake, again, as the interpreter, you know the magnitude and direction. Once you know the magnitude and the direction of an error, you are in the driver's seat to make a rational judgment as to whether that measurement needs to be repeated or not. Now here we're measuring a biparietal diameter, and we have the third ventricle and the thalami, so the level is correct. But we can see that the plane is inclined because while we have a nice smooth calvarial margin on the downside, we have an irregular calvarial margin here. The beam has gone through the anterolateral and posterolateral fontanelle. So it went in lower on the calvaria and came out higher on the calvaria. So if we measure that, we see the measurement comes out to be 73 millimeters. So again, we know that it's an error, but you can appreciate that the direction and the magnitude of the error would typically not indicate that it should be remeasured. Now again, we want to do the measurements perfectly, but if you're planning that every measurement you ever look at is going to be perfect, you're in for a lot of disappointment. What I'm telling you is that you have to have a handle on the magnitude and the direction of the error. Then rational judgments can be made. Now here, the plane of section is too high. We are above the level of the third ventricle and thalami. In fact, we are even above the level of the lateral ventricles. If we measure the head circumference here, we see it comes out to 251. If we measure the biparietal diameter there, it comes out to 71. So again, you can see that the magnitude and the direction of the error, well, first of all, the direction of the error is that the head circumference turns out to be too small, the biparietal diameter turns out to be too small, and you can appreciate that the magnitude is sufficient, that this would be an appropriate time to go back and take a remeasurement, or alternatively, another possibility is that you can simply eradicate the head circumference and the biparietal diameter from the computations. Okay. Look, when we first started to measure the biparietal diameters, first of all, why did we do it? Well, we did it because when obstetrical ultrasound first came along, they needed a database against which to know what kind of measurements they could obtain. And for many, many years, nurses in the nursery had been taking a caliper and measuring the biparietal diameters of newborns of premature age and term. So there was a large database of biparietal diameter measurements. It was also true that pathologists measured the biparietal diameter of abortuses. So there was a large database. So that is why people began measuring the biparietal diameter as the first obstetrical fetal measurement. Now, the way the nurses, of course, did it was to put the caliper to the widest point between the parietal eminences. So that is the way that ultrasonologists first began to measure the biparietal diameter. So they were looking for the largest measurement. So if they had measurements of 55, 57, and 59, they naturally assumed that 59 was the correct number. Then along came an investigator, an ambitious young investigator who said, you know, what we really should do is always measure at the same level of the brain. Not always search for the widest biparietal diameter, but always measure at the same level so that if somebody measures a biparietal diameter in France and somebody measures a biparietal diameter in the United States, we both did exactly the same thing. We didn't search around for the biggest number. We searched until we got the exact plane of section that we wanted. So we tested the third ventricle and thalami versus the top of the third ventricle and thalami versus the bodies of the lateral ventricle, and the top of the third ventricle versus the bodies of the lateral ventricle. And what you can appreciate is that there was a remarkable correlation between any measurement that we chose. So as long as you do the same measurement over and over again, in exactly the same way, your correlation coefficients will be astronomically high. So there is no downside to always measuring at the third ventricle and thalami. And this way, everybody does the same thing, no matter where the biparietal diameter is measured. And that caught on. So now you are instructed in the AIUM ACR ACOG guidelines to take the measurement of the biparietal diameter where you see third ventricle and thalami. The next thing that's important is to use measurement data that is internally consistent. Now, everyone has their heroes in medicine, and my hero is Frank Hadlock. When Frank Hadlock came along, fetal measurements were the biggest mess I had ever seen in my entire career. And I mean, it was an unfathomable mess. Nobody felt comfortable trusting fetal measurements from anybody. Along came Hadlock, and he completely changed that. And because of that, this guy threw out all of his measurements and adopted Hadlock's measurements. And in fact, if you look on your machine, the probability is extraordinarily high that your manufacturer chose to adopt Hadlock's measurements as well. So you can see here that even by parietal diameters, by different well-known examiners, could have quite a bit of difference within the same gestational week. So again, my recommendation and what I personally do is use Hadlock's data at every opportunity. Hadlock doesn't have data on every last aspect of fetal measurement, but he certainly has a ton of it, and I use Hadlock's data where available to me. Now, one of the other things that Hadlock taught us was that if we were going to just choose one measurement to predict menstrual age throughout gestation, then the head circumference is our single best measurement. Yes, it's technically more challenging than some of our other measurements, but in fact, it predicts what we want it to predict the best. However, he also taught us that once we pass 24 weeks, biologic variability becomes sufficiently large that extraordinary caution is required when we are thinking about changing a patient's dates. For myself, I never do it. I never change a patient's dates after 24 weeks. Now, I'm not saying that someone couldn't do it rationally, but what I'm saying is that the probability of getting in trouble doing that is greater than the probability of coming up with a better solution to a given clinical issue. The other thing that Hadlock taught us is that if in fact we took all the measurements and tossed them together in a polynomial regression equation, we actually get the best accuracy of prediction across the trimesters of pregnancy. Another way to look at this is to think of all of these sonographic predictors as predicting plus or minus 8% in days. So whatever fetal week you're looking at, you can say a standard deviation is plus or minus 8%. That's remarkably accurate for a host of measurements. I don't know why exactly, but it is remarkably accurate for a host of measurements. So again, you can appreciate that once you pass 20 weeks, variability is no longer insignificant and caution is appropriate. So again, between 20 and 24 weeks, I'm very interested in seeing whether size predicted, age predicted, and dates from the last menstrual period correlate or not. If they do not correlate, I do not draw a conclusion as to why they do not correlate after 20 weeks. So once you pass 20 weeks, caution is required. Once I pass 24 weeks, I do not use ultrasound dating. So if size and dates do not match, I believe that you are obligated to use the patient's dates. So if we're going to use patient dating, we know that that's problematic because patient dates are not infrequently erroneous. How is it that we judge the adequacy of menstrual age? What is it that constitutes good dates as opposed to bad dates? Well, the patient has good dates if they have a certain last normal menstrual period. Preferably, they wrote it in a calendar and are not simply doing it by recollection. And also, the person interrogating them has explained that they're looking for the first day of their last normal menstrual period because patients will often remember the last day. The patient needs to have regular menses, and preferably with a 28-day cycle. Once women get out to a 36-day cycle, then using their dates has some inherent inaccuracy. The patient should not have had exposure to oral contraceptives in the past 6 months, and the patient should not have had any unusual bleeding events. So this constitutes good dates. Everything else is bad dates. My rule, however, is that in the absence of a more scientifically determined gestational age, the last normal menstrual period must be used. What is a more scientifically determined gestational age? Any mean sac diameter or crown rump length from the first trimester of pregnancy. Measurements of the fetal biometry prior to the 20th week of pregnancy. Those are uniformly believed to be more accurate than patient dates. I'm not saying that an obstetrician will invariably change the dates if those measurements do not match the patient's last menstrual period dates, but these are scientifically valid means of determining gestational age. So, another would be, for example, if a woman was taking her temperature to time ovulation. Another would be that the patient received a dose of a hormone to stimulate ovulation. Another would be any woman who underwent assisted reproductive technologies other than the ones I've already mentioned. So all of those can be considered scientifically valid and can be used to supplant the last normal menstrual period as appropriate. Otherwise, I always use the patient's last menstrual period. If the obstetrician wants to change things, that's up to them. As a sonologist, I use the patient's last normal menstrual period once I pass 24 weeks, unless there is valid scientific evidence that it's wrong. Now, when we start to get out into later pregnancy in a patient where the dates are not good and things don't match up very well, I have found that looking for epiphyseal ossification centers is a very useful tool. I'm talking about identification of the distal femoral epiphyseal ossification center, which on average appears at around 33 weeks. Now, that is more definitive for a male fetus than for a female fetus because female fetuses mature more rapidly than male fetuses. So we are talking about seeing the distal femoral epiphyseal ossification center, which is the secondary ossification center of the fetus, fetal femur. This is the primary ossification center, the secondary ossification center. So if I see a distal femoral epiphysis, I assume that the fetus is most likely 33 weeks or more. Now, that I can then compare to my measurements to see if that makes sense. Another thing that you can do is to actually measure the diameter of the distal femoral epiphysis. If it is 8 millimeters or more, you may reasonably assume that the patient is near or at term. The proximal tibial epiphyseal ossification center appears at around 35 weeks. Again, that's more definitive in a male fetus than it is in a female fetus, but it's a good starting point. So you can say, I see it, I look at it, and I see that the fetus is measuring around 35 weeks. So it gives you a check that the measurements seem appropriate for that particular fetus. Now, if the proximal tibial epiphysis actually has a wider width than the distal femoral epiphysis, then again, you may reasonably assume that the fetus is at or near term. The proximal humeral epiphysis shows up at around 38 weeks on average. Again, this is more definitive in a male than a female fetus, but if I see a proximal humeral epiphysis, I want to see fetal measurements that tell me this is a near